the district health system in Ghana, the health system is very decentralized. I mean, and the district is the operational unit of all health delivery. So the district hospital, and then you come to, within the district, we've divided it up into sub-units that we call sub-districts. And then within the sub-district are communities. So the health system, we try to establish services at all this level and link them up. So we have the district hospital, and then we have health centers, which are the next level, which are usually manned by physician assistants. And then we have the community level, where we have what we call the community health nurses offering service. And that's how the health system is arranged. In Senate District, where I've been working for the past 6 years, there are 5 sub-districts. And we have what we call the 3 health centers. And then the Kwame Danso Health Center, which was originally there, was in 2005, they upgraded it to a hospital. And that is when I went there to start the work. And these are the health facilities that we now have. I mean, the 3 health centers, the hospital, and then what we call the CHIPS compound. That is the community-based service delivery. The doctor population now is the district is 1 to 102,000. Now I'm the only doctor for the whole district. For Ghana, it's now 1 to 10,000. So I mean, it gives you an idea of how things are. And the next to population ratio is 1 to 3,000. So the hospital is the referral center for, the whole district. But this hospital was not in existence till 5 years ago. We more or less created it out of nothing. So the initial challenges that I had when I went there was that we didn't have adequate health staff, because nobody wants to go there. I mean, like everywhere else, everybody wants to be in the city where the action is. Nobody wants to be in the rural area. So it's not only, I think it's a universal problem that we are grappling with. Health workers want to be in the city where the action is. And then we had inadequate flow of funds, and then the high cost of delivering health service on island, because you need to take boats to reach the people on the island, and that was a problem. And then we have very limited infrastructure when we started out, and we have inadequate skilled and unskilled staff. Because I was the only doctor, I had only 1 midwife for the whole district. For 1,000 or 2,000 people, only 1 midwife. And the road network is very bad. So normally, the way our system is organized, you can be, I could have just been there and not be bothered. I'll be there, and at the end of the day, every month I'll collect my salary, and the system will be just as it was. And that's the old way of doing things. You just wait for the government to do what you want to do, and you are just there. And nobody will bother you. Yes, nobody will bother you. And that's the way, and then the old ways, that's how you do it. But then I wasn't satisfied, because, the district needed to have a referral center where we can deal with things. Because you see mothers coming in labor, they need cesarean section, you need to intervene, and you need to refer them to the hospital where they can do it. And I thought it wasn't right. We need to do something for them. So the thinking then was that let's look at the situation. And that was the thinking process, and that was what I'm calling a paradigm shift. That what do we have now? Where do we want to be? How do we get there? What are people who can help us? And those are the thoughts that I had in the initial year that I was there, trying to set up the system. So with that, analyzing what we had, then we decided that, fine, we'll start with what we had. So we improvised. We actually improvised. So we had a room, and then the room, we got a delivery bed that you can see. And if you look very closely, there are bricks below the delivery bed. Bricks. And that was my first operating table. That was what I used to do my first surgical cases. I put a delivery bed on bricks, and then I got a surgical lamp from somebody. And then we had an emergency cesarean, obstructed liver, the woman couldn't deliver. And then we did it. And then people saw that, yeah, these people can do surgeries. And they started bringing their surgeries. And we've been doing quite a lot of surgeries till then. So we were, the whole thing, once that one started, then we decided, where do we want to be? So now we have a strategic plan for the hospital, and this is how we want it to be with, everything is sorted out. So now we go around shopping for people to help us set things up in a very good way. So far, what have we been able to achieve? We saw that we need to be part of the world. We are geographically removed, but we can be part of the world with internet. So that was one of the key things. So we felt, an NGO in the USA, Access to Health, who we've been working with on improving health information in the district. We linked up the district by VSAT so that we have 24-hour internet access. We can go online if we have some medical problem that we are not clear about. We can take pictures, take the case history, send it out to somebody who can advise. So that, we don't need to send our clients out because the roads are bad. Most of them have never gone to the city. And sending them out sometimes is a problem and they wouldn't be able to do. So that was one of the key things that we did. And we had somebody to support us, and that was Access to Health. And then also, we saw that we need to manage our data well. So now we're working with some people, Global Alliance for Vaccine Initiative, and then the Ghana Health Service to develop a data system that will, you need evidence-based to make decisions, and we are looking into that. And then also, we saw that we need to improve our diagnostic abilities. So that one we rode on the back of the National AIDS Control Program. They wanted access for clients for antiretroviral treatment. And said, oh, we told them, look here, we are ready, we want to do it for you, but we don't have a lab, will you come? So they said, okay, fine, bring a proposal, we'll set up a lab. So we set up a lab. So now we have a laboratory that not only will cater for the HIV clients, but will cater for everybody who comes to the hospital. And it's a very nice, simple, small lab with everything in place that will offer quality care to our client. And now we started a 40-bed male and female ward that will provide good congenial atmosphere for our clients who are admitted. And that one we got funding also from the National AIDS Control Program and then the MP. And then United2Heal, we'll be talking with them for them to provide a furnishing for the ward, which is a very great thing that we're doing. And then we are having now, we are putting up a proper theater block for us where we'll be doing the surgeries, which, we'll move from our small improvised theater to a modern theater where we can handle more cases. And with staff accommodation, that's one of the key things that is missing. When you do not have accommodation, then you cannot bring skilled staff in. So we are working on that also. Getting the district assembly, that is the political authority, we'll be really pushing them that look here, we need to get staff, so they are putting up more staff accommodation for us. And that one has helped us tremendously, bringing in more qualified nurses and midwives. Now we are moving from 1 midwife to 5 midwives, which is a huge achievement for the district, which is very helpful. And these are some of the staff quarters that we've been able to do to collaborate to let it come on. And we're looking at a transition plan because I cannot be there forever. We need to get a transition in place and somebody else. So we're getting the medical director's bungalow, a house that the new doctor who comes can stay in so that we can improve the doctor to the population ratio.